25-year-old gentleman presented to the emergency department with history of taking 40 tablets of paracetamol over the last 24 hours in order to kill himself. He's known to have depression, and the blood tests it showed that he requires antidote. But now he's refusing and he would like to leave against medical advice. So what is your approach? Hello everyone, this is Muhammad Fagir. I'm one of the co-founders and instructors of Emergency Medicine Academy. And before getting to our topic, I would like to thank all our colleagues who attended our most recent 25th MRCEM OSCE course in Riyadh, Saudi Arabia at the end of May 2025. We hope them the best in their upcoming MRCEM OSCE exam. And we are glad to announce our upcoming course, which will be the 26th MRCEM OSCE course. We are planning to run it again in Riyadh, Saudi Arabia, between the 4th to the 8th of August 2025. So see you there. Let's get back to our topic. Today, I would like to talk about one of the most important topics in medicine, and this is the mental capacity. And it has particular importance in emergency medicine because we are the first line to meet the people. So, what's mental capacity? Mental capacity is a person's ability to make their own decisions at the times when it needs to be made. In the UK, it's defined by the Mental Capacity Act 2005. And it stated that the Mental Capacity Act 2005, it provides legal framework to protect and empower vulnerable people who are not able to make their own decision. So, for example, you have someone who is quite unwell and he's septic and confused, and you need to decide for him, or if he's not having capacity, or if he does have capacity, then he's going to decide for himself and to agree or not agree to what you are planning to do for them. So let's explore more. And before getting to more discussion about mental capacity, just I would like to highlight that there is some situation not covered by the Mental Capacity Act. One of them in children who are under 16-year-old. So this category is covered by the Children Act 1989. So we can't use Mental Capacity Act in children less than 16-year-old. Regarding young people who are 16 and 17, they are covered with Mental Capacity Act. However, they can't make advanced decisions and they can't appoint lasting power of attorney. And for some mental health issues, or for most of the mental health issues, it's appropriate to use the Mental Health Act rather than Mental Capacity Act. However, there is a lot of interaction between the Mental Health Act and Mental Capacity Act, as we are going to discuss later on. So let's talk about the most important point when you assess mental capacity. And these are the principles of mental capacity. So principles of mental capacity, it should be in our mind all the time when we deal with people in the emergency department. Without having good knowledge about principles of mental capacity, we are likely to mismanage issues related to mental capacity. We have 5 principles. The first one is presumption of capacity. And that means any patient presenting to the emergency department, we should presume that they have full mental capacity to decide for themselves unless proven otherwise, and not the reverse. So I'm going to give you an example. If you've got a patient who is coming with acute behavioral disturbance, accompanied by like 7 police officers, agitated, we can't just assume that they lack capacity because of that. Or if we got someone with mental health problems, we can't assume they lack capacity because they have psychosis. But we must presume that they have mental capacity, and until we do our assessment, and then if it if we found that they lack capacity, then we will manage them on their best interest. All right. So this is the first principle, presumption of capacity. The second principle, and that we need to support people to make their own decisions. And I believe this is the most important principle for mental capacity. Let me explain more. So to support someone to make their own decision, then we need to, first of all, we need to explain to them the situation in full details. So, for example, this gentleman who presented with paracetamol overdose, we need to explain to them the risks of having paracetamol overdose, and that it will likely affect their, it's going to damage their kidney, damage their liver, affect their brain, and likely they are going to die. But if they accepted to have the antidote, then likely their condition is going to improve, and also they will need mental health assessment. So you must provide full explanation about the medical condition, to support them to know the risks and benefits of that particular intervention before just assessing the capacity and let them go. The other thing, to support them, we need to explore their concerns. So I would make that really simple. If someone would like to leave, or he doesn't like to have particular treatment, before attempting to convince them, explore why they are refusing. And sometimes you might be surprised. For example, someone might say, I didn't, or I haven't eaten anything in the last 24 hours. I'm really hungry. So we can provide them with some, sandwiches, coffee and tea, and that might solve the problem simply. Or if someone would like to pick his children from school, we can help. Or if someone is having an appointment, then he would like to go to work, we can support them by writing a letter to their work, or something like that. So we need to explore our patient concerns. Okay, offer help to solve the issues that preventing them to accept your advice about having treatment or having investigation. Also, one of the important things we can do, we should involve significant others. And what I mean by significant others, regarding the patient, we can, after their consent, we could involve their next of kin, their loved ones, best friend, family member, to try to convince them. But we need to take consent from the patient first. Also, we could also offer to, if you are the emergency medicine registrar, for example, then it would be appropriate to involve your consultant, your nurse in charge. Sometimes we might involve the medical team, the mental health team. So all these people might help to convince the patient to stay. Okay? So support them support them to make their own decisions. Number 3, people have the right to make what sounds like unwise decision. So let's have an example here. A patient presented with chest pain, and his ECG showed ST segment elevation, and your clinical impression, this patient is having STEMI. You offered him the management according to your hospital guidelines, but he's refusing, he would like to leave. So, given that he is taking what looks like unwise decision, that doesn't mean he lacks capacity. And all of us at some points of our life, we make unwise decisions. And I'm sure you would like to be respected when taking these unwise decisions. So we should respect people when they have or they make what looks like unwise decision, given that they are fully understanding the risks and benefits of their decisions. All right. If someone is lacking capacity, then how, on which ground are we gonna manage them? We are gonna manage them on their best interest. And this is the fourth principle of mental capacity. If someone is lacking capacity, we should manage them on their best interest. Best interest, it depends on the clinical situation. For example, if you have an elderly gentleman, but otherwise he's healthy and fit, and he goes out every day, he doesn't have any major medical problems. If they came very unwell, then if you believe that they are for full escalation, including ICU admission, then that's on their best interest. On the other side, if you have a patient who's quite unwell with multiple comorbidities, and you believe that, for example, if their heart stopped, it would be inappropriate, to perform CPR because it's highly unlikely to is going to manage to restore his heart working again, or it's highly unlikely that they are gonna, you know, uh, have their baseline level of alertness and consciousness if they develop cardiac arrest. Then, after discussion with your team and relevant other specialties, you might conclude that you are going to provide the full treatment. But if he developed cardiac arrest, his best interest is to be not resuscitated. So that medical decision might be the best for this particular patient. I'm sure that will be discussed with the family as well. And this is just an example, okay? And let's talk now about the fifth principle of mental capacity, and that's if we need to restrain a patient for any reason, then we should use the least restrictive option. For example, if someone brought to emergency department in acute behavioral disturbance, quite agitated, then it's better to use chemical restraint rather than continue on physical restraint for long time, which might pose risk to the patient life and to the whole staff and others involved. So always use the least restrictive option. Another example of the least restrictive option, if, for example, you have a septic patient and he's refusing to have blood tests and cannula to be inserted, then we might provide him with tiny dose of benzodiazepine just to calm him a little bit so we can proceed and get the blood test and give him the appropriate antibiotics in timely manner. Okay, so these are the principles of mental capacity. Let's recap the principles again. Presumption of capacity, support people to make their own decision. People have the right to make which sounds like unwise decisions. If someone is lacking capacity, then we manage them on their best interest. And lastly, if restraint is needed, then that should be the least restrictive. Okay, let's move. There are some situations in the emergency department where likely we need to use mental capacity act. For example, if someone is refusing treatment, or if someone is presenting with mental illness and would like to leave, or in case of someone with confusion. Sometimes people presented with head injury and they refuse our advice. If someone presented with low GCS, if someone presented who is heavily intoxicated, and usually we use it for our patients who have chronic conditions, for example, like dementia, where we need to, talk to them and assess their mental capacity to make sure they understand what we are doing and what they need. And also, don't forget the absconded patient. That someone came to the department, but he left before being fully assessed. So these are some conditions which we might need to use the Mental Capacity Act. Now, let's talk about mental capacity assessment. How do we assess mental capacity? So, number one, we need to make sure that they understand the information. And as I said earlier, we need to explain to them in full details everything related to their presentation and about, what we think is better for them in terms of investigations and management, and what might happen if they refused. Okay? And then make sure they retain the information. So ask them to repeat back to you what you've just told them. And then we need to make sure that they can weigh up the pros and cons of their decision, and that they are fully aware about all the consequences of their decision. And the last thing, we need to make sure that they communicate their decision to us, and that could be by any means. So if communication could be verbally, could be by using a sign language, or by any other means, writing down any other means. So mental capacity assessment, it's understanding the information, retaining the information, weighing up the pros and cons of their decision, and communicate their decision. Okay? There is important things to put in mind. Mental capacity, in best, is an opinion. So sometimes we might have a patient and you assess him and you conclude that he lacks mental capacity. But then one of your colleagues performing assessment and stating that he deemed to have full mental capacity for them. And then a third practitioner assuming that he lacks mental capacity. So mental capacity at best is an opinion, okay? And mental capacity, it's for particular decision at particular time. So it's not for everything. So for example, for this particular patient, he's having capacity for, consenting for having investigations, but he does lack mental capacity for deciding to leave against medical advice at this time. So mental capacity is for particular decision at particular time. Okay? And there is important point I would like to highlight, because there is a lot of confusion about it. So if we have someone who is known to have mental illness, or he's showing evidence of mental illness, and he presented now with self-harm, those people must be assessed by the mental health team before leaving the hospital. Someone might argue, if this patient is having full mental capacity and he would like to leave, then we can't stop them, we can't force them to see the mental health team. However, there is a subjective element in the mental capacity assessment, you know, weighing up, make sure that this patient can weigh up the pros and cons of their decision. This is subjective. And for me, if I might think this patient is having full mental capacity because he understands the consequences of his decision. But for you, you might, conclude that you don't think he's having capacity because you don't think they understand the risks and benefits, and they are unable to weigh up the pros and cons of their decision because they might be something, clouding their mind. For example, if someone is having severe depression, this depression might impair their mind at this point, and that's why they are not able to clearly understand the consequences of refusing what you offer them. So this is really important points. And if we go back to all guidelines, the Royal College of Emergency Medicine, the Royal College of Psychiatrists, all these guidelines, it's clearly stating that if someone presented with mental illness and self-harm, then they need to be seen by the mental health team before leaving the hospital. Okay? And as I explained, the subjective element in mental capacity assessment, which is the ability of people to weigh up the pros and cons of their decision, this is sometimes could be quite difficult. And sometimes we need to involve senior members of our teams or other teams. And we stated earlier, mental capacity at best is an opinion. So this is important. All right. So the conclusion of this point, mental health problem plus self-harm equals they need mental health assessment before discharge or before leaving the hospital. I'm happy to discuss more if someone would like to discuss more about this. All right. Fine, let's move. So there is some practical points I personally encountered during the years, and I would like to share with you. Hopefully that might, just make sure we will not be confused at the time when we need to be concentrating and take the right decisions. If you have a patient who presented to the emergency department accompanied by police, then we need to understand, we need to ask the police officers, are they escorting the patient, or is this patient under arrest, or is he under section 136? These are the three situations where police might be accompanying the patient. So escorting him, or under arrest, or under section 136. Because if they are escorting the patient, then they might want to leave early after bringing the patient to your department. Sometimes we have a discussion with them if we don't think that's safe, but they have the right to leave early because they are just escorting him. If the patient is under arrest, then they need to stay with the patient along with his journey in the emergency department. And if police are, bringing someone to the emergency department under section 136, and I'm going to talk shortly about it later, then they cannot leave until the patient is having full mental health assessment. Sometimes we might have a patient who is restrained by police, possibly because of he was quite violent, or because that patient might be posing risk to himself or to others. And when you come to assess the patient, sometimes the patient might ask for the police to go outside the room because they are not going to talk in the presence of police officers. So basically, we need to respect our patient's privacy. That's the general rule. And if you think that's safe, then we should respect that and ask the police officers to, to stay outside the room, for example. However, if there is concerns about safety and if the police officers believe that this patient might pose risk to himself or others, then they have the right to stay. You cannot force police to go out. So have that discussion with police, and if they believe there is, considerable risk of having you alone with the patient inside the room, and they would like to stay, then they should stay. All right. And also sometimes people might come handcuffed, and they ask for to release the handcuffs. Again, have the discussion with police, and if they think it's posing risk to you or to others, then and they wanted the handcuffs to stay, then yes, we should respect that, and handcuffs should not be removed. But if you think that it's safe, and you have the discussion with them, and you do your de-escalation techniques, the verbal and non-verbal de-escalation techniques, sometimes you might need to use other means. And if you think it's safe to remove the handcuffs, then after careful discussion with the police, you could consider that. But if police officers are insisting to keep them, then keep them. Okay? Regarding Mental Health Act, so in the emergency department, we cannot use Mental Health Act. We cannot apply it ourselves, because to apply Mental Health Act, most sections or particular sections, for example, Section 2, Section 3 of Mental Health Act, that needs two healthcare provisionals. One of them should be Mental Health Provisional Section 12 approved. So I can't, as emergency medicine doctor, just come and section someone. Okay? So I'm going to briefly talk about few sections which are related to emergency medicine, just to have basic understanding of them. So earlier I mentioned Section 136, and Section 136, this is used by police to remove someone from public place if they feel that they have mental health problem and that they might be posing risk to themselves or to others. So that patient, usually police take them to a place of safety. And typically, emergency department is not place of safety. However, if the patient, sometimes or most of the time, people might need physical assessment to make sure they are medically fit before having the mental health assessment. And that's why frequently they come to the emergency department. So this is Section 136. And usually it lasts for 24 hours. So the police can hold the patient for 24 hours. And sometimes it could be extended by additional 12 hours. So until the patient is having mental health assessment. All right? So this is Section 136. Section 2, again, Section 2 of the Mental Health Act. So mental health team or liaison psychiatry sometimes might put a patient who's having mental health problems under Section 2, and this is for assessment, and it lasts for 28 days, and it cannot be extended. So mostly this is for assessment, but sometimes it could be used for treatment as well. For example, if we've got a patient with overdose and they need antidote, and he's been assessed by the mental health team, and they believe that they have taken an overdose because of their mental health problem, and we couldn't manage them by the Mental Capacity Act, then at some time it could be appropriate to use Section 2 to manage them, to manage their overdose, if we believe the medical problem is a consequence of mental health problem. Okay? Also, there is Section 3. Frequently, we hear that in the emergency department, someone under Section 3 of the Mental Health Act. So those patients, they are admitted to mental health facility for 6 months. So Section 3 is for 6 months admission. Sometimes it could be extended up to 1 year. Okay? So these are the sections. There is Section 5 too. This is for inpatient patients, so those who are admitted to the hospital. So we cannot use it in the emergency department, but it could be used by inpatient teams. For example, the medical team could use it in the acute medical unit or any other ward in the hospital if someone needs urgent treatment against their and they are lacking capacity, okay, or posing risk to themselves or to others. And Section 5.2 is applicable for 72 hours, okay, but this is not applicable in the emergency department. Let's talk a little bit about common law. So let's say you have there is a patient in the waiting area, and suddenly he started to shout and started to pose risk to himself or to others, would like, to assault someone else, or he wanted to, kill himself. Then there is no time to assess his mental capacity or assess his mental health. In these grounds, we could use common law, to protect the patient or to protect him and restrain him, okay, until he's having formal, mental capacity assessment or mental health assessment. But immediately we could use common law to protect people from harm, okay? So this is the common law. There is something called lasting power of attorney. And what's lasting power of attorney? It's a legal document in the UK that lets someone to appoint another person to make decisions on their behalf if they lose capacity in the future. So, for example, an elderly gentleman appoints his son or his daughter as his lasting power of attorney. If in the future, if he lost his mental capacity, his son or his daughter will be having the lasting power of attorney and can have decision on his behalf. Okay, we have two types of lasting power of attorney. One for health and welfare, and the other one for property and financial affairs. But the health and welfare is the one which is related to us as emergency medicine practitioners. Okay, this document must be registered with the Office of Public Guardian before it could be used. All right. So this is regarding the lasting power of attorney. And if you remember, those between 16 to 17, they don't have the right to appoint lasting power of attorney, but everyone over 18 does have the right. Okay, fine. So let's have some examples, and hopefully these might just remove any confusion. So let's go back to our first patient, the 25-year-old who presented with paracetamol overdose, intentional overdose, and they are known to have depression, and they require treatment, but they would like to leave now. So this patient, if you assess, first of all, I would presume that he has mental capacity, and I'm going to, go to them. I'm going to collect the whole information from my team, from the hospital system, to see all the investigations, to see their medical background. Is there any mental health problems or crisis? The blood test results, or whatever investigations performed. So when I collect the whole information, then I will go to the patient, and putting the principles of mental capacity in the back of my mind, okay, I will support them first, as we said, support patient to make their own decision, and I will explain to them everything related to paracetamol overdose. If they accepted to have the treatment, if they refused, what are the possible consequences, okay? Um, and then I will explore their concerns, why they are refusing, if I can do anything to convince them to stay and have the treatment. If all that is not working and still they are insisting to leave, then I would offer to involve significant others. And again, if that's not working, I would assess their mental capacity. Okay? And remember, mental capacity assessment for particular decision at particular time, at best, it's an opinion. Okay? So for this patient, sometimes they might seem that they have full mental capacity because he can understand, he can retain the information. He sounds that he can weigh up the pros and cons of his decision, and he can communicate his decision. However, given that this patient is having history of depression, then that will make me not 100% sure that they can weigh up the pros and cons of their decision. And the guidance is clear from the Royal College of Emergency Medicine, and there is a great, document about Mental Capacity Act. I would encourage everyone to go and read it in details. Okay, it stated clearly that if there is evidence of mental illness and present self-harm, then they should be seen by the mental health team. And my understanding, this is because of the point that I'm not going to be able to make sure they can weigh up the pros and cons of their decision, which is one of the important things when assessing mental capacity. So this patient should be seen by the mental health team before leaving the department. And if the mental health team concluded that their, for example, mental health problem, their depression, is likely obscuring their mind and affecting the way they are, managing their thoughts, and that's likely, uh, clouding their mind, then they might, put the patient under section. And if they put him under section, you might be able to manage their paracetamol overdose under that section, because the reason behind taking the overdose is their severe depression. However, if the mental health team believe that their mental health problem is not related to this overdose and the patient is sounding to have mental capacity, then they have the right to leave. Okay? So this is the first scenario. Always consider to talk to your senior, to your colleagues, involve others, because sometimes it could be quite difficult to conclude whether the patient is having full mental capacity or they lack mental capacity. Fine, let's take another scenario. So 25-year-old male without past medical history, they came with supratherapeutic paracetamol overdose. I mean, it could be any other medication, but the most common is paracetamol, but it's not necessary to be, all right? Supratherapeutic overdose usually people presenting to us because of having severe pain like toothache, and they come to the emergency department because of the toothache, but then we tell them that we are concerning about paracetamol overdose, and we need to manage that. So they get upset because they came for something, but now we are addressing different issue. If the patient would like to leave again, you should presume that they have full mental capacity, support them to make their own decision, explore their concern. You don't know. Sometimes people might refuse to have the antidote because they are needle phobic. So in this situation, for example, for paracetamol and the patient is needle phobic, we could offer that we can apply cream, to numb the area. Sometimes they accept. Or if they are not accepting at all to have any injections, then we could offer to, give them the N-acetylcysteine as a liquid, which is the same N-acetylcysteine but orally, but in different dose. Okay, so you need to explore your patient concern. You need to find alternatives if possible. Fine, and if we assess their mental capacity and they deem to have full mental capacity for this decision at this time, and still you try to involve significant others, you did your best to convince them, but they are refusing, then despite sounding like unwise decision, they have the right to leave because there is no evidence of mental illness. So you cannot, and they deem to you to have full mental capacity, you cannot keep them by force just because you think their decision is unwise. But if you did your best to convince them to find alternative, to involve others, to give them full explanation, likely they will accept. All right. Let's take another scenario. 72-year-old female with past medical history of hypertension and diabetes. She came complaining of chest pain. Her ECG is unremarkable. Her troponin is very high. So you are, concerning about acute coronary syndrome, probably non-STEMI, and the patient would like to leave. Then does she lack capacity, or does she have full mental capacity? Does she have the right to leave? Given that if not treated, she is likely going to die? Well, this patient, without any evidence of mental illness, and given that you presume that she has full mental capacity, you support her to make her own decision. Okay, I'm keeping repeating that just to make sure these steps we are going to follow it every single time. We support the patient to make her own decision. We explain that her heart enzyme is very high, unlikely she's having heart attack. If she accepts to stay, the heart doctor is going to help. They are going to, decide on the best management for her to go back home at the end of the day in good health. But if she refused, then likely her condition is going to deteriorate. Her heart is going to, fail to do its function, and likely she's going to die. And try to, involve significant others, any relatives, any friends, next of kin, after her consent. Also your senior colleagues or your consultant colleagues, the nurse in charge. Our nurse in charge are really expert, and please, in these situations, involve them. Okay, they are really helpful, and definitely they will add much, and they will help, and most of the time they help to convince patients to accept the appropriate management plan. Think about involving the medical team, the mental health team. If you exhausted all you know, uh, your um, options, and the patient is still willing to leave, and you concluded that they deemed to you to have full mental capacity for this particular decision at this time, then the patient, she has the right to leave against medical advice. Then if someone is leaving against medical advice despite all of that, then still support them, give them treatment if any could help at home. Make sure to contact their GB, okay? Um, so do everything you can do to, to help. It's not like this patient refused, then this is not my problem, and I'm not going to do anything more. All right? Let's have another scenario. A 10-year-old brought to ED quite agitated. We don't know any history about the patient, but he's quite agitated, and there is a lot of police officers with the patient. So, and your colleagues are asking, come and give him something to calm him or calm her down. Probably consider some benzos. So please, before doing all of that, if there is no immediate risk, okay, where you should use or we should use the common law, try first to de-escalate. Try to, keep bring the patient to a calm area as much as you can, and try to de-escalate. Try to talk to the patient, reassure them, okay. Introduce yourself, okay, by name and your position, and you are here to help, okay. Stay at the level of the patient, okay, as long as it's safe to do so. Sometimes, or most of the time, verbal de-escalation is everything we need to do. All right, but sometimes we might need to, to go for further steps. So try to explain to the patient, and then try to assess their mental capacity. Explain to them what's going on. They are quite agitated. You need to assess them. You need to help them. You need to do some investigations to help, and then ask them to repeat back. So assess mental capacity. If they deem to you to have full mental capacity, then you can't administer them anything by force. But most likely in these situations, they will not be able to, to understand or retain the information and repeat back to you. So if that's the case, then you conclude that they lack mental capacity, then you should treat them on their best interest, because physical de-escalation is quite dangerous if continued for a long time, okay? And sometimes people might die because of prolonged physical restraint. So possibly you might need to use some chemical restraint, all right? But then document carefully in your notes if that you have tried to de-escalate, you assess their mental capacity, they deem to you to lack mental capacity, and in the balance of probability, you decide that you need to manage them on their best interest. All right? Let's take a different scenario. 76-year-old male brought to ED confused, febrile, smelling urine, and your nurse told you that he's refusing blood tests and antibiotics. So I think I spoke about this earlier. So this is someone with acute confusion state, possibly because of sepsis, and likely that's urosepsis, but it doesn't matter, okay? Because acute confusion state could be because of anything. Sepsis, electrolyte disturbance, DKA, hypoglycemia, hyponatremia, acute coronary syndrome, stroke, intracranial bleeding, whatever, okay? Anyway, the patient is refusing. So again, we need to go to the patient. We need to support them, putting the principles of mental capacity. We don't assume that they lack capacity because they are confused. Please don't assume that, all right? After supporting them, if still you couldn't convince them to have the investigation and blood tests and antibiotics, then assess their mental capacity. And if they deem to you to lack mental capacity, then your legal duty is to manage them on their best interest. So in this situation, think about other options, how to calm the patient down a bit in order that you can take the blood test in order to administer the timely antibiotic. Okay? You might need to consider giving them small dose of benzodiazepines, given that they are in a monitored area and you're going to monitor their blood pressure and oxygen saturation and make sure they are safe. All right. Let's have another scenario. 46-year-old, past medical history of schizophrenia, and came to the brought to the emergency department shouting on staff. Again, please don't assume this patient lacks capacity just because the history of schizophrenia. Okay? Because you remember the first principle, presumption of capacity. So come support the patient and talk to them, de-escalate, explain to them what we need to do next, why are we concerning about them, okay? And the other thing, you assess their mental capacity, and if they deem to you to lack mental capacity, then treat them on their best interest, okay? Fine. If someone is posing immediate risk to your staff, to others, to themselves, and there is no time, as we said earlier, we will use the common law. Okay? If we have someone with low GCS, okay, then we will try to do our assessment, but obviously they have very low GCS, and you are going to conclude that they lack capacity, then you should treat them on their best interest. All right? Let's take this scenario. 84-year-old lady, past history of hypertension. Her husband died 2 months ago. She came with history of taking beta blocker overdose, intentional overdose. And when you talk to her, she said she would like to end her life. She doesn't like to live. She's very calm. And when you explored more why she would like to die, she said that her husband died 2 months ago, and she feels that her life doesn't matter, and she would like to join her husband. When you assessed, you explained to her, supported her, everything. When you assess her mental capacity, she sounds that she understands the information you provided. She's able to retain the information and repeat them back to you. She sounds that she can weigh up the pros and cons of her decision, and she can communicate her decision. So in this situation, it's quite difficult to conclude that this patient is having full mental capacity and she has the right to live against medical advice. And that's because of the subjective element in the mental capacity assessment, which is the patient able to weigh the pros and cons of their decision? Because the profound grief about the death of her husband, which was quite recent, that could be obscuring her mind, that could prevent her from, having the right decision to consider everything related to having the overdose and the risk of death, because the only thing in her mind that she's quite sad and she would like to join her husband. So in this situation, it would be appropriate to involve the mental health team, because if she's quite depressed, this depression could be the reason that her mind is not clear. She's unable, to balance the risks and benefits. And if the mental health team concluded that the depression is causing or she's lacking mental capacity because of her severe depression, then you might be able to manage her and save her life. On that grounds, the mental health, if the mental health team put her under section, then you will be able to use it, okay, uh, to manage her overdose, because at the same time you are unable to use mental capacity act to manage her overdose. So at the bottom line, if someone coming with mental health problem and there is a history of self-harm, they must be assessed by different legislation, which is the Mental Health Act, before leaving the hospital. Okay? The last scenario, 37-year-old lady admitted to a mental health facility under mental health section, whatever, okay? And today she's brought to your emergency department because of medical problem, all right? And at some point she wanted to leave against medical advice. What are you going to do? Shall we use the Mental Capacity Act, or shall we use the Mental Health Act she is under, or what shall we do? So the answer to this, if someone who's already under mental health section, for example, section 2, section 3, section 3741, or whatever, okay, if they presented with medical problem to emergency department, medical problem means physical problem, then we use Mental Capacity Act. If they presented with solely mental health problem, then they should be managed under Mental Health Act. Okay? So for this patient, because she presented with medical problem and the treatment is not complete and now she would like to leave, then I'm going to assess her mental capacity. And if she lacks mental capacity, I'm going to treat her on her best interest. If she sound to have full mental capacity, then I would review her Mental Health Act section she's under, and I will have discussion with the mental health team to see whether we could treat her on that basis or not, and then take it from there. So in real life, it's not straightforward, but if we know the basics, then we will be safe and our patients will be safe. And remember, we are not cowboys. Always, if you are not sure, take to your colleagues, talk to your seniors, okay? They will help. Best wishes. I hope that give you an overview about mental capacity in the emergency department. And next time, we'll talk about other important topics. Thank you.